Right. Thank you everyone for joining us today. We are on the 4th of July for the APAC Scientific Forum. Okay, let's move on. Yeah. So today we have the A-Star team. My team from A-Star is happy to be here to share more about our prediction study. In fact, this was our study in the 2022 Datathon, and we have plans to actually take this forward into a validation study in the upcoming Odyssey APAC Symposium hybrid event with the Datathon as well. So share more about this study and hope to get more partners into this study. Okay. Then I have Sharifa from my team who will be switching over the slides.
Hi, everyone. Okay, I'll be sharing. So, are you guys able to see the screen?
Yeah.
Yes, we can.
Okay, so I'll start. Okay,
Let's go
so
ahead.
yeah. Hi, my name is Sharifa. I'm from SICS Data Management Team. So, as what Mukesh mentioned, we'll be sharing with you about a project that we had back in 2022 for a Datathon event. So, in our study, we are using a real-world data set and then having AI to predict the post-surgical complication risk for patients that's going through elective surgery. So, the outcome is that for the AI to predict if the surgery will be at higher risk or lower risk for complications. Okay, so in a real world problem, we have about 300 million surgeries happening in a year, 5% post-operative mortality and 50% post-operative complications here. So what we propose is that to have a decision support tool for surgeons to predict the post-surgery complications using clinical risk factors. So what happened is that before patients went for surgery, they would take some lab tests, etc. So the results that we get is incorporated into the AI machine learning model, and then the AI will predict if it's an acceptable risk, so that they can proceed with the surgery, or it's a higher risk, which means that the surgery may need to be deferred or needs more further counseling sessions. Okay. And the data that we are using is from VitalDB database. It is for surgical patients and it is based in Seoul, Korea. And we are using about 4,221 patients with pre and post operative lab biomarker data, as well as demographics data as well. Okay. And in our study, what we consider a case to be a complications if it follow any one of the three following conditions, and they are in hospital mortality, duration of ICU that stays 2 days or more, and then having post-operative acute kidney injury. So if the condition is one of the conditions that you would deem has a complication in our study here. Okay. And from the model results, we are using this gradient boosting feature selection model, and it shows us AUC of 0.89, which is quite high. And the top three risk predictors are patients that's going for transplantation surgery, and then C-reactive protein, as well as platelet count here. And further on, we wanted to obtain a more optimum model result. So we actually further constructed this model using the top risk predictors here. And it resulted us in two-tier model. So the first tier model covers 4 features, while the second tier model covers 12 features here. So looking at the first tier model, we only have 4 features. Again, it is the transplantation surgery, and then having high level of C-reactive protein, high level of platelet count, and low level of fibrinogen here. So from here, we could see that there's only 4 features that it takes to predict if the surgery will be at a higher risk or low risk here. So looking at this, it is actually quite easily implementable in a real world clinical settings, because all you need is a blood test, and then you look out for these 3 lab biomarker data, and then an information to know if what kind of surgery that they go for. So we also compared our AI predictions with the data literature, and it coincides with our findings. So let me just briefly go through a bit. So for the first one, transplantation surgery, it has been shown in the studies that it increased the risk of surgical site infections, and this entails a longer hospital durations here. And for the second one, C-reactive protein, a well-established marker of inflammation. So having high CRP indicates an inflammatory response here, and this can lead to complications like infections, cardiovascular events, and also prolonged hospital stays and resulted in ICU. So ICU is also one of the conditions that I mentioned earlier on. And for the third one, platelet count, a cells that helps the blood clot. And if we have high level of this, it increases the likelihood of thrombotic events and can be worsened by surgery. Lastly, fibrinogen, a protein that helps to stop bleeding and support wound healing. So low levels of this will lead to uncontrollable bleeding and also increase the risk of AKI, acute kidney injury. Again, one of the conditions that fits inside the complication risk here. So these are the four features that our model predicted to be a high risk to predict the surgical risk complication here. And as for the second tier model, on top of the four features that we mentioned, we have additional of 13 more features that is a mix of lab biomarker data as well as non-lab biomarker data, demographics data like their age and BMI. So in a case, if there is a need for a comprehensive assessment for the patient's profile risk, the surgeons may look into this to see, to have a more comprehensive view on that. Okay. And yeah,
Can I ask
so
what is?
yeah, sure.
Can I ask how you can distinguish first and second tier? Is it based on the performance of the models? Because
Yeah, correct. So
it seems like
basically,
a lot.
yeah. So in the model is we actually have a lot more than just this. So we are choosing the best two models, basically. Yeah.
But based on the ARC, like I think that first tier model has lower ARC, isn't it?
Yeah. Yeah, but we are also looking at how
Wow.
it can be easily implementable into the real world clinical
Right.
settings.
So it means like it's kind of a simpler model. Like
Correct. Yes.
right.
Yeah. Okay. Yeah. So yeah. So in the upcoming Datathon event here that's happening this year, we will performing ML validation with the 4 external data sets here. So the first one is Singapore preoperative data set, which is based in Singapore. And then Inspire, a publicly available research data set that is based in Seoul, Odyssey Thailand's EHR, and Odyssey Data Partners tentatively. And moving forward, in our plans is that we are actually currently during the development of the Asian predictive model, the project that I just shared, to publish a paper for this. And afterwards, we will go for the ML validations with the external data sets at the Odyssey APAC symposium. And lastly, to have a larger scale of ML validation with the MOH Trust. So MOH Trust is basically a database that is for whole of Singapore EHR. So it is a much more intensive data here. So yeah, I think that's all. And this is our group back in 2022 here. Thank you.
Thanks, Sherry. Well, I think there's a
Okay.
raised hand from Song. Yeah.
Oh.
Yeah, so guys, I'm not so I'm an idiot around statistics and AI, okay? Apologies for any ignorant questions that I might ask. But so the data model you developed is using a database in Korea called VitalDB, right? My question is, if you want to train that model using if you want to use that model and take it to other databases, won't the data format or the data model be a problem here? I'm just trying to understand how you will be able to take that model and run it on the 3 or 4 databases you had and the plans that you presented just now, right? So can you help me understand whether or not that's possible? If it's possible, how much complexity that will be, and etc. Things like that. Please try to educate me like I am a elementary student, okay? Because I am very, very stupid around AI stuff. So yeah, please.
Well, it's not that complex. Sharifa, you want to explain or you want me to?
I think,
Okay.
yeah, you can.
Okay. Well, with the first project, right? We've used a VitalDB data set to actually train a model. So that's a trained model. So think of it as you have a file output from this model, right? It's a pickle file. So that pickle file is what we're going to use on the validation. So, and for the validation, ideally, you'll want to have similar features. So Sharifah showed in the first year, there were 4 features, right? So in the validation cohort, you're hoping to see similarly those 4 features available. And then what you're doing is basically you're applying those 4 features, say now from the Inspire dataset, right, onto the trained model. And then you'll get a prediction output. So that's the inference you'll get based on the trained model. And then you will sort of have an output that says whether it's high risk or low risk. And then you have the ground truth in the actual data set. So in other words, you are validating the model independently on other data sets that the model has not seen yet or trained on. Right. So that's the independent validation. Hope that
No, like
yeah.
I get it, but
Yeah.
sorry, Chan. Please, thank you for educating me. This is great. Question, right? So, for example, the first tier model, you selected 4 predictors, 4 features that that predicts the complications, right? Yes, the other databases should have those 4 features, but how would that AI model know what codes to identify those features? Like I might be asking dumb questions. Tell me if I'm asking dumb questions, okay? But like I'm just wondering, how would the features be identified in the new data sets, and how would the outcomes be identified in the new data sets, right? Because it's not the same model. I mean, not the I mean the data model, not the model, right? So, yeah. Am I asking a dumb question, guys?
No. I think these are all very data-centered questions. So I think that's where the OMOP CDM also helps, right? To help us harmonize the data sets together. But essentially, it's the variable name. Now, imagine in the first model that was trained, we've used variables as A, B, C, D. And in your independent data set, you're hoping to see the A, B, C, D columns appearing, right? So that ABCD data set is what I'm giving to my trained model because it recognizes ABCD. So I have to give it to it in that format of ABCD columns. Does that make it easier to explain? So in other words, we have to harmonize the data sets, yes. So that's where we are looking at possibly using, the OMOP concept IDs as a way to recognize these terms, aligned. Yeah.
Chan?
Actually, my first question is very similar to the song's question. Like, so you mean that this project itself is not actually related with the AMOPSI because none of these databases are in the format of AMOPSI. Am I right?
Yes.
Okay. So yeah, so they need to manually create the data for to extract these features from each data set, like from Aspire or the other data sets from Thailand or the Singaporean nationwide data set.
Mm.
But my question is that you are trying to predict the post-op risk, like and then there are 3 outcomes like in hospital mortality, and I don't know the second thing, and third one is that ICU hospitalization. The third one is that there's the AKI, acute kidney injury. And so for the second outcome, I think that all of the patients after transplantation will be sent to the ICU. It's a very standard process. All patients, but after the kidney transplantation will be sent to the will be cared in the ICU just right after the surgery. So that can be another bias, and then the other question is that you extract the perioperative values like platelet and fibrosis, and which is very very relevant values to predict the patient outcome. I do not have any doubt about that, but still how did you define the perioperative? Is it 1 or 2 days before and after the operation, or what is the definition of the perioperative, and what is the actual outcome? You would have the single outcome. Is it the composite of the 3 outcomes, or you do have like 3 different models?
Yeah, so for the perioperative variables in the VitalDB dataset, we have data up to 14 days before the surgery. So that's 14 days prior to the surgery. That's what we are using here as the predictive features.
Then it is preoperative. pre-operative.
Yeah,
you know,
sorry.
just
Yeah,
right before
pre-operative,
the surgery.
Sorry, yeah,
But-
that's pre-operative.
But I do not think that fibrinogen, we test the fibrinogen before the surgery. Fibrinogen, we usually test the fibrinogen after the surgery, not before the surgery, or at the day of the surgery. That's right after the surgery.
Okay.
That
Yeah,
is not
that's-
routine test for the
yeah.
surgery.
Yeah, let us check the data set again about the fibrinogen. But it's a good point though. Yeah. Because we use the markers from the VitalDB data set. And yeah, let us have a double check that, whether it's in fact before the surgery or it's after the surgery. Yeah. Okay. And I think the second question was, yeah, I think Sharifah had a slide. It is a composite right now in terms of in-hospital mortality, duration of ICU stay, and post-operative AKI. But because what feature showed up as risk was, of course, any transplantation, but we do have also patients who don't go transplantation surgeries as well. So it's actually a binary variable. Yeah, so it was one hot encoded. So that's what we are seeing as transplantation showing up as a risk factor as expected.
Yeah, of course, it is very highly risky procedure. There is no doubt that it's the most risky procedures among the surgeries, the transplantation itself. But just what I said is that the outcome, one of your outcomes from the composite outcomes that going to the ICU care is that is just routine care for the patient with very highly risky surgery, such as transplantation.
I see Morning in the call.
Yes, I saw that as well.
Yeah. Okay.
Yeah, Mukesh and team, thanks for sharing, and thanks for acknowledging Straight 2020 and also mentioning our data done this year. Actually, working together with Song and team, and also our collaborator SyncHealth, very nicely aligned. We are trying to prepare a perioperative data set from SyncHealth and see whether we can get it mapped to at least most of the data mapped to almost CDM before our event, right? And whether the community can conduct some studies before the event, and of course, more importantly, that I would like to invite our community to work together around Singapore and then South Korean and other regions data sets during our data dawn as well.
Morning, you just spoiled the great announcement we were planning to make in 2 weeks.
Okay, sorry. No, you didn't hear anything. My bad.
My
bad.
Yeah, so just to add to that, yes, there is some talks about doing some community-wide effort to get some data sets available during the datathon, so / the APAC symposium. But it was supposed to be a surprise, but Morning ruined it.
You guys didn't hear anything. You guys didn't hear anything. Okay, yeah. Look at my thumb flashlight. Okay, you forget what happened in the last 5 minutes.
But if I may, we are eager to participate in that datathon as a data partner as well. That's why I just wondered about the data format and the outcomes or compare it, because we need to prepare for that if we participate as a data partner.
Yeah, that'd be great.
Fantastic chance. I was about to ask you and all the other leaders in APAC for help for during our next APAC.
I cannot let Seoul National University is the sole data partner of Korea. I cannot let them.
Now you're seeing the typical Korean competition here. This is bad. This is bad influence, or is it good influence? I don't know.
I don't know.
We do our best to turn it to some positive, constructive competition.
Of course.
I agree. I agree. So yeah, so this is definitely a conversation we should have at the upcoming steering committee meeting, Chan, Morning. So yeah, we can talk next week about the details and fine tuning what's needed moving forward. So for the rest of the community here, I guess the key message here is please stay tuned and definitely join us at the upcoming community call. We will probably have some announcement to share that is very relevant to what we are talking about right now. So nothing's formalized yet. So like, please disregard Morning. He puts in so much hopes, but like we have tons of real things to figure out. So yeah, let us figure that out in the next 2 weeks, hopefully, and we'll come back to the community with a formal announcement. Now we have a question in the chat from Subin to Sharifa. She's asking, what criteria did you use to select the features for the tier 2 model? Was it based on variable importance or clinical relevance? Can Mukesh,
Yeah.
yourself or Sharifa answer? Yeah.
Oh yeah, maybe Mukesh, yeah.
Okay. Yeah. So we use the sharp feature importance value, the Shapley values, as a cutoff. That's how we determined the first tier and the second tier model.
Subin, does that answer your question?
Yeah, thanks for your answer.
Okay. Any other questions for Mukesh and Sharifa here? Fok?
Focus.
Yeah, hi Mukesh. Thank you for sharing, Sharifa. My question is about the setting of the study. I wonder, like, what is the observation period of the study and how you set up the time at risk for every outcome? Yep. And the other question, I forgot that. Yeah. That is my first two questions about the model.
Yeah. So the implementation is actually planned to be at a pre-surgery level. So ideally, you're looking at maybe a month before the surgery, where actually the patient has a consultation session, and this model actually tells their risk for their post-surgical complications. So you're looking at at most a month, before the surgery. Yeah. So that's the window period, and of course during that period is where you will of course have information about the participant, about the patient, right, in terms of their lab test results and their intended surgery types and other surgical related information. So with that, the model takes those input and it gives you the possible outcome, right? Whether you have high risk for surgical complications or not. So if you're at a high risk, then what might happen is the surgeon will probably have a consultation session with the patient to discuss whether to go forward or not, given their makeup and their background. Yeah.
Yep. Thank you. And yeah, the other question is about the discrimination of the result. You just showed the AUC. So apart from the AUC, how about the discrimination portion of two outcome? Are they overlap or are they totally distinguished between two outcome group?
Yeah.
Yep.
Yeah. So I think right now we are using AUC and of course your F1 scores as the metric to optimize this model. It's essentially a classification problem, right? Whether you have a high risk or low risk there. Yeah. So it's a classification problem and we're using AUC metric to optimize the models thus far.
Yeah. And last, sorry for asking many questions. And the last question is like, if we want to use our team use the Obsidian to participate in your study, what is the criteria to join with the team?
Yes, definitely. I think that's why I think we wanted to take this opportunity to share with the community. We are on the lookout for partners in the Odyssey community to join us in the validation. I think the essential part is the features that Sharifa showed, the first tier and second tier, whether we have those features in your home Obsidian data sets. I think
Could you share the share the features from the second tier?
Yeah, Sharifa, maybe
there are many
show your
features.
Yeah.
So while Sharifa gets that up, guys, like my question is also related to this, right? So say, Mukesh, you and Sharifa want to recruit more data partners. How would you send something over to the data partners and how would they run it on their databases, right? Because I'm just entirely knowledgeable about only the Odyssey stuff, right? We would have an R package where people would run it. But here, I think the situation is a bit different, right? Because you've now trained this on a non-OMOP data set. Yes, I understand the features need to be there, but how would how much input from the data partners will be needed in order to run this against their OMOP databases, right? So yeah, I'm gonna stop there.
So from my perspective, many of these features can be derived from the standard OMOP common data model from the EHR. But the one thing the American Society of Anesthesiologists grade system, it's not usually in the usual OMOP data of EHRs, and it is actually the classification of the risk of the surgery. So actually, I'm not sure that whether it seems fair to use this, because it's another grading system from the anesthesiology department to predict the post surgical risk. So I thought that your model will be compared with this grade, but you are using this grade as a predictor. I'm not sure whether it is good or bad strategy. But anyway, it cannot be populated in the usual OMOP common data models of EHRs. The other things will be easily populated from the CDI.
Yeah, correct. And also, I think just to add a bit of context, this work that we are showing was our data tone work back in 2022, which was non-OMOP work, right? And of course, if we are going forward in the OMOP direction, likely we will adopt the OMOP framework, like the PLP packages to work through, and that will help us to synergize our results. Yeah.
Indeed.
Yeah, I would say that some of the features you show in the list is not available right now in our database. And the prediction is quite very crucial for in the surgical situation in the long in the short term, because that's also one of the very huge physician concern about what would happen after the patient they get the surgery. So yeah, I would love to if you can share that in the MOF CDA packages or in the RDC's format is more feasible for our database to run your study. Thank you.
So we have tons of features for the second tier one. Can we pop up the first tier one again so that folk? I think the first tier one is better, right? I think you probably have it.
Yeah, at the moment the lab test and the procedure is not available in our database.
Okay.
But I will see how maybe in the very near time we gonna input those kinds of the feature within our database, so it is feasible to run those kinds of the features.
Sharifa, sorry, I just realized the second tier actually includes the first 4 of the first tier. So
Yeah,
sorry for making you
It's okay.
flip those slides again.
Yes.
We also think that the first tier will be probably easy to go into a network study approach in the Odyssey level because it's easily done. We took a quick look in the Inspire dataset. That's also from SNU, but it's much bigger. I think there's about 130,000 surgeries. The 4 features are available in Inspire. So where we're hoping to see is, like, of course, in the Singapore perioperative dataset that Maureen mentioned, hopefully we can see at least the 4. And then in Thailand and of course other partners, if we have those 4 features, I think it's easily a network study that we can pull together.
This sounds exciting, right? Like adopting a non OMOP model into a OMOP model and seeing how it performs, I think is very interesting. So yeah, look forward to the progress. Of course, the progress is sort of dependent on how well or host of the APAC symposium is going to push things moving forward. But yeah, let's see how us as a community can make this happen. So this sounds great. Any other questions, guys? Like, I know sometimes we're very shy to ask questions. We ask questions in the chat sometimes, but I think this is great, guys, because the more discussions we have, the more we make sure everybody is on the same page on these kind of things. So, anybody else? I think that's all. Mukesh, do you have anything else that you had prepared, or this is all for today, right?
Yeah, I think that's all for today. Good. Yeah. Okay. I think we're all
let's.
well.
I think we can close off the call, right?
Yes, I think we're good for today. And yeah, let us know if you want to know more about the study, and of course the features we've shared. We'll share those information as well. Yeah, I think if not, yeah, we are good for today. We're a bit early than usual. We'll have a follow-up call in 2 weeks' time, and I think there we'll share more exciting stuff that's coming up for the upcoming APAC symposium preparations. Yeah. Okay. All right.
Okay,
Thanks, everyone.
Sharifa,
Yep.
I'll reach out to you for the slides. Okay.
Sure.
Thank you so
Okay.
much.
Thank you so much.
Yeah, sure.
Good job.
Okay, thank you.
Thank you.
Bye. See you.
Bye.
Thanks everybody.
Goodbye.
Bye-bye.
See you.